Welcome to the webinar. Tonight's webinar will be presented by Laura Kaur, who is our musculoskeletal fellowship candidate. And I'm going to have Laura present her presentation. So over to Laura.
Okay. Hi, I don't know who's on, but all right.
We're
So
recording this
tonight,
session, so just do it for everyone. They're going to
okay.
watch this later. Yeah.
Okay. All right. So tonight I'm going to be talking about a couple of different ideas or uses for MSKUS. One of them being utilizing MSKUS to measure a DRA. And I'm going to get into that in a minute as to explaining what a DRA is. I do a lot of women's health in my clinic, so I do see a lot of women who have this problem. So I found it interesting to figure out an angle on how to use MSKUS to actually help me in assessment and treatment of this. So I'm going to start off by just talking about what the anatomy of a DRA is, which stands for a diastasis recti abdominis, or you can say diastasis recti abdominis, however you want to say it. So basically the abdominal wall has 5 paired muscles. We have the rectus abdominis, we have the external and internal obliques, we have the transverse abdominis, and we also have the pyramidalis, which is a new muscle for me. I didn't realize that was one of the abdominal muscles. That was interesting. They attach the thoracic cage, the pelvis, and the spinal column. And the right and left sides of the rectus abdominis is connected via the linea alba aponeurosis. So basically what happens is that during pregnancy, that linea alba reduces resistance to tension, and the 2 bellies of the rectus abdominis, so we're going to call it RA, curve around the abdominal wall and increase that midline separation of the 2 rectus abdominis muscles along that linea alba. So that increase in that, we call it the interrecti distance of that rectus abdominis muscle, is due to a stretching of that linea and of the linea alba and a thinning of that linea alba. So on the next screen, I have basic anatomy of the abdominal wall. Here is our rectus abdominis. We have our external oblique. We have our internal oblique. We have our transverse abdominal muscles. And along here, running from your xiphoid process all the way down to your pubic symphysis would be your linea alba. So this is a picture showing basically an idea of like what it would look like once, say you're pregnant. And so you can see on this side, we have the linea alba, all together here. And then you can see on this side, we're getting basically the stretch or the separation here from that linea alba. So you're getting a big span across that navel region. Everybody thinks that a diastasis recti is actually a separation of the muscle, but it's actually really a stretching of that linea alba. And this would be kind of like a side view or a slicing view, which is almost like the image you're going to see on an MSKUS when you're doing it. You're going to note it. You're going to see here's your rectus abdominis on the left, the linea alba in the middle, rectus abdominis on the right, and your oblique muscles on the side. And this is basically what I'm talking about when I'm saying it's being stretched. So it's just a little bit more elongated along the middle there. That's the linea alba. So what is a DRA? The DRA is the gap that is formed between the rectus abdominis, and that is called the diastasis recti abdominis, or DRA. We measure it by the interrecti distance, which refers to that measurement of that gap. So an increased DRA may affect about 30 to 70% of women during pregnancy, and it may remain separated immediately postpartum. Common treatment methods for a DRA would include bracing, physical therapy techniques, and surgical intervention if it's really bad. So the problems that a lot of women get associated with the DRA, they get a lot of pelvic and low back pain. They're going to get, obviously they'll have weak abdominal muscles, they'll have poor core stability. They'll definitely have a weakened lumbopelvic stability. And the other problems that they may have is pelvic floor dysfunction, which could include incontinence, pelvic floor pain, and your urgencies and all kinds of pelvic floor dysfunctions. So how do we usually measure the interrecti distance. In physical therapy, the most common method to evaluate that interrecti distance is through manual palpation. So the procedure for that is that the patient is usually lying hook-lying position with their head resting on a pillow. The physical therapist palpates that space with their fingers horizontal to that space at rest. Usually we measure about 3 points. One point is 3 centimeters above the navel, at the level of the navel, and 3 centimeters below the navel at, at a resting position. And then the patient is asked to perform a head lift, and the physical therapist palpates that space while the rectus abdominis is activated by recording how many finger widths are measured in that interrecti distance. So basically, the measurement is correlated to centimeters. For example, if you feel 2 finger widths in that space, it'd be considered about a 2 centimeter gap. So you measure that at rest, and then you measure that when they're performing a head lift. So a DRA would be considered to be present if you're able to place at least 2 finger widths or more in that sulcus between the recti during a head lift. So this is a picture of what I'm trying to explain, is that here's the fingers within that sulcus. These would be the, palpating in between that. You're going to be palpating right between that rectus abdominis. You can see it a little bit better in this picture. So the reason why we want to measure this, the importance, is that obviously it's needed to screen for it, to see if it's present and if it's clinically relevant, especially if somebody was postpartum and they're complaining of back pain or pelvic pain or any kind of instability and weakness. You always want to check to see if they have some sort of DRA. It's also needed to monitor over time to evaluate the effectiveness of treatment methods. So if they do have a DRA, you want to see if your treatment methods are successful and benefiting the patient. You also want to determine the best course of treatment for them. So you want to determine, whether they need a brace, whether just PT intervention is sufficient, or if there's something, gets to the point where it's really severe, then obviously surgery would be an intervention for them as well. So the pros and cons of measuring manually is that the pros, it's easy to apply, does not require any special equipment, just basically your hand. And the reliability is reliability is good if the retesting is done by one rater. So the intra-rater reliability is good. But the cons would be that you need to be accurate and have reliable palpation skills required. Therefore, the inter-tester reliability may be affected if it's measured by different clinicians. Obviously, the difference in the width of your fingers could be an issue, and subjective interpretation of pressure can make measuring unreliable. So we've decided that MSKUS could be a good means to measure that interrecti distance. And this would be a picture of somebody holding, the sensor, the probe across that person's recti, their abdominal region. So the pros of measuring with the MSKUS would be, when it's performed by an experienced clinician, the intra-rater reliability was high when measuring the interrecti distance between sessions. It has reportedly produced consistent interrecti distance measurements between sessions when performed by the same operator. The inter-rater reliability of the interrecti distance above the umbilicus was good to excellent, poor at the umbilicus, and fair to good below the umbilicus. These inconsistencies may be due to variations in probe placement and pressure. The probe placement error can be avoided, though, by using consistent measurements and marking to assure accuracy. So overall, ultrasound in the literature is showing that it's more reliable and valid method to measure IRD. But there are cons, obviously, with everything. So the cons of measuring with the MSKUS would be, one would be that the borders of the recti abdominis are less clearly defined, therefore it may be more difficult to measure consistently. Women with severe diastasis recti, the width of that linea alba may be so large or larger than the width of the transducer. So in certain machines, you may have to use a panoramic view to see a wider field of view. You could do a split screen view and add the measurements from the midline to the left and the midline to the right. You also, if you apply too much pressure, you can deform the image, but however, too little may not give you sufficient image due to inadequate contact and decreased visualization. And in some cases, it may require specialized equipment such as an acoustic standoff pad, which I've never used, so I'm not really sure too much about it. Maybe later on, Mohini can explain that. So this is basically the image that you would see doing a measurement with the MSKUS. So obviously this first layer here is your skin. This is reverberation artifact. The second layer here is your subcutaneous tissue. And on the left side of the screen, this oval here is the rectus abdominis muscle. And if you see this thin band running across here, that's your linea alba. And on here is your right rectus muscle. I'm sorry, your left rectus muscle. And underneath here is your visceral fat. So this would be the area that you would measure from the end of this rectus muscle across the linea alba to this rectus muscle. And that would be considered to be the IRD, the interrecti distance. So I have a patient who has a DRA, so I try to do it myself to see, how this would work out. And this is basically the scans that I came up with. This would be the patient scan at the navel. These are at rest. So this would be at the navel distance. So you can see point A over here. This is the linea alba in the middle. So you can see it's about 1.58 centimeters. And then when I had her do a head lift, it was about 1.44 centimeters. So almost about the same. So at the navel, it didn't really separate too much. Then below the navel, I had a distance, you can see here's the one side of the rectus abdominis, here's the linea alba, and here's the other rectus abdominis. I had about a 1.5 centimeter difference from side to side. And then when she did a head lift, she actually pulled together a little bit and she had a 1 centimeter difference. And then when I measured her above the navel at 3 centimeters, it was about 1.1 centimeters. And then when she lifted up her head, it actually separated a little bit more and it went to 1.7. So I compared those numbers to my manual palpation just to see, what the difference would be compared to the MSKUS. And when I measured her at 3 centimeters above the navel, which is the one that had the most significant difference, at rest, I measured 2 finger widths, which would be 2 centimeters. And when she did a head lift, I came up with 1.5, like 1.5 fingers. So if you look above the navel, when I measured it with the MSKUS, I actually only had about 1.1 centimeters, and with the head lift, I had 1.7. So, it was a little bit off, in the measurements. And then at the navel, I found 3 centimeter difference, 3 finger widths in between. And, whoops, sorry. And then with the head lift, I had 2.5 finger widths. So you can see at the navel, I had 1.5 with the MSKUS and 1.4 with the head lift. So that was a big significant difference compared to the 3 centimeters that I saw manually. And the measurements 3 centimeters below the navel at rest, I saw 2 centimeters difference with the fingers. And with the head lift, 1.5. So you can see below the navel, it was a little off on that measurement too as well. So you can see how the accuracy, comparing the manual way and using the MSK was a little bit of a difference there. So basically, in conclusion, when you're using MSKUS, when it's performed by an experienced clinician, that intra-rater reliability is high when measuring between sessions. It has reportedly produced consistent interrecti distance measurements between sessions when performed by the same operator. If done manually, accurate and reliable palpation skills are required. Therefore, intra-tester reliability may be affected if measured by different clinicians. And if done manually, difference in the width of the fingers and subjective interpretation of pressure can make measuring unreliable. and that MSKS is the preferred method to measure IRD in patients with DRA. And that's about it. Does anybody have any questions?
Yeah, Laura, I have a question. This is Vicky.
Hi, Vicki.
Hi. My question is, so I was actually a little surprised that the diastasis closed in certain times when you had her do the head lift.
Mm-hmm.
I'm sorry, the other way around, opened. You had it splitting. Most of the time, what I found just manually whenever I do it is that the diastasis sort of closes up around your fingers,
Yeah,
when you do
it
the
could
head
go.
lift. So
Yeah,
I
it could
was,
go either way. And actually, if you notice, hold on, let me go back. So at the navel, if you notice, it closed up a little bit. Went from 1.58 to 1.4, and then see it closed up a little bit, like about a half a centimeter below the navel. It actually did come together below the navel, but she had most of her separation was more above the navel, so you could see it opened up just a little bit when she performed the head on. And that could be also poor, like I wasn't cueing her to pull together and do the right,
right,
to actually
right.
pull the navel in,
Mhm.
zip it up kind of thing, the cues that you would use to instruct the patient. I just wanted to just have her just do it and not give her any cues on the correct way to do it. So yeah, go ahead.
And I have a comment here. So that's interesting, actually. It's a good discussion also. In the the current slide that you have on, so with your palpation, you were picking some type of closure, right? No, not separation. But here on ultrasound, you have the IRD increase from 1.1 to 1.7. But if you also look at the image, you have some contraction. So you can see rectus belly nice and thick on the right side of the image when the patient is
Mm-hmm.
doing head lift. So I think what's happening is because muscle is now contracting and now there's more tone. The displacement of soft tissue is towards your probe or superiorly. So if you put finger, you will feel muscle contracting, and because that's displacing everything. From palpation point of view, it may appear as if there's closure of the distance, while there isn't, because it's just a superior displacement of the belly.
Mm-hmm.
So you're not, like that's what I think. What I
Yeah.
understand from looking at the images and
Right.
understanding why there's a discrepancy here.
Yeah. And that's the other reason why, the palpation skills there's so much more room for error, because you're just going by what you're feeling and what you
Yeah,
think is there. Where with the MSKUS, you have right in front of you, it's more accurate. It's right there. As long as the therapist or the clinicians that's performing the MSKUS knows exactly where to put that probe placement, so if they measure correctly and they put markings on their stomach and they say, okay, we consistently keep measuring at the same spot, it's so much more accurate. It's the room for error is a lot less.
yeah.
Any other questions?
No, great presentation. Thank you, Laura. This is Brian.
Thank you. You're
Yeah.
welcome. All right. Okay, so now I got to get to my second one. Let me just, if I just go this way.
Laura, how much time do you think it would take you to do these measurements on patients when you have like suspicion?
When I'm actually doing those,
Yeah.
it's not long at all. It's really just a matter of seconds, because you're putting it on their on their belly. You're just measuring it out. You're 3 centimeter up. You got your navel. You measure up 3 centimeters, put a little marking, and you're basically just placing that probe horizontal and taking a picture, having to do a head lift, take another picture, label it. It really doesn't take long at all.
I
Very
have a
quick.
question.
Yeah.
So, I noticed that a lot of men have this problem too, especially the more corpulent individuals.
Mm-hmm.
I noticed that they also have it's more of a three-dimensional type of situation, not just separation. Have you thought about measuring the height? Measuring from the inferior aspect of the rectus abdominis to the height without, and using the standoff might help out in this as well. The standoff is just basically a rubber piece, a silicone piece of rubber that goes around the ultrasound head. But I look at the fact that I see women and men with this problem, and in men, they tend to have this huge presence of basically fat that comes out and pushes out through it.
Right.
So maybe there could be a two-dimensional measurement rather than just the separation alone.
Well, that would be interesting to do, actually. I haven't done that yet. I actually haven't done men. I've only been scanning my female patients, but that would be a good
And this is a
study
joke.
to do as well.
This is a joke. That's because men don't have health issues.
Well, maybe that'll be my next presentation.
Yeah.
Well, I've got a bunch of fat men around here, so I might just do it myself.
Okay.
And let me also add one more thing to like the standoff, because Laura mentioned that we're going to talk about this. So what standoff does is, like, especially when you're scanning superficial structures, and that can be anywhere else, like in the digits or any superficial structure, it puts the focal point at that specific structure. So when your structure of interest is too superficial, you cannot focus much there, because the beam, there has to be certain distance in the near field for so the focal point can only be so much closer to the transducer. So when you move transducer away by putting the standoff pad there, it brings the focal point to structure of interest in the superficial layer of the tissue, so that enhances its appearance.
Okay.
Yeah, I think you did well without that, but yeah, I can see standoff pad being of great value. Another thing that I would do or change is maybe increase the gain. I think the first image at the level of navel was a little darker. So if you increase gain, you may see the separation or linea alba a little bit better.
Do you want me to go back to that scan or no?
No. Just wanted
Okay.
to comment on that. No, it's okay. Yeah, we can move to the next case.
Maybe,
Any other questions?
Yeah. Maybe you didn't have to go so deep as well, and that might have cleared some things up as well.
Yeah, that's another good point. Yeah.
But it looks great. You did a great job. That's awesome.
Thank you. Thank you. I wanted to do something a little out of the box in terms of utilizing MSK, and just kind of give ourselves another avenue of what we could possibly be doing, with it, and using that as another more, a little more of a screening tool, assessment tool, rather than just the extremities.
Very interesting. Thank you.
You're welcome.
Good job, Laura.
Thank you. Okay, so then this next one is a little bit more straightforward. This is just a case study on how, utilizing MSKUS to diagnose Achilles tendon tears. This is a little bit of a journey of a patient that I just wanted to share with you, and, show you my findings of what I found while I was treating this person. Basically, the background information on this patient is she's a 58-year-old female. She's a yoga instructor. She came to the clinic, via direct access, with complaints of pain and swelling in her Achilles and her lateral ankle. So her history came about. She said she had an onset of left ankle pain in October 2017. She was doing a deep squatting exercise. And she said also at the time she was wearing shoes that were rubbing her posterior heel region. At the time, she reported lateral ankle pain and burning. That began about a month after that. And she reports, also that she takes spin classes once a week, and she also would have pain following each class, and also when teaching her yoga classes, and also pain when descending stairs. In And during her evaluation, she told me the only thing she had done at that time was just an x-ray, and that the doctor told her that she had a bone spur in her Achilles region. So I did her evaluation. You know, she had pronated feet, splayed toes, she had mild tibial internal rotation, hip internal rotation. There was significant amount of swelling noted at the distal insertion of her Achilles and posterior lateral ankle region. There was tendon to palpation noted in her posterior lateral malleolus along that peroneal tendon region and along her lateral lower leg and her gastrocsoleus muscle belly. When I had to perform a single leg stance, she was able to hold it, but she had a lot of instability in her medial lateral ankle with overfiring of her anterior and lateral ankle region. She had limited joint mobility in her talocrural joint. She had decreased posterior glide of her talus. Her active range of motion, ankle dorsiflexion on the left was about 5 degrees, and on her right was about 10 degrees. And her plantarflexion was normal. She had about 4 out of 5 in her plantarflexion, dorsiflexion, inversion, and eversion. So her strength was pretty decent. So I decided to perform an MSKUS at the time of her evaluation. So I just want to go over a little quick anatomy of the Achilles tendon. I mean, obviously everybody knows this, but I just go figure everybody can get a little review. So your Achilles tendon or heel cord is also, also known as your calcaneal tendon. It's calcaneal tendon. It's the tendon on the back of your leg and the thickest in the human body. It serves to attach the plantaris, the gastrocnemius, and soleus muscles to your calcaneus bone. These muscles are acting via the tendon, cause plantar flexion of the foot and the ankle, and flexion at the knee. So here's your Achilles tendon coming down, inserting at the calcaneus. And here's a picture of medial lateral gastrocnemius muscle, Achilles tendon, plantaris tendon, all coming together to form the Achilles tendon, inserting at the ankle, the calcaneus. So, looking through studies, there was a lot of studies that used MSKUS to diagnose Achilles tendon tears. And basically what they came up with was that MSKUS can differentiate between micro, partial, or full tear of Achilles tendon or tendinosis with an accuracy of 92%. So ultrasonic signs of acute tear include markedly distorted fibrillar architecture, hyperemic edge of the torn tendon, hematoma, and gap at the rupture site. So basically, if you're doing an MSKUS of a normal Achilles tendon, this is what you're going to see. You're going to see good orientation of the fibers along that long axis of the tendon with tightly spaced echogenic parallel lines and a fibular pattern. Here would be your calcaneus. This would be the area where if you would have like a retrocalcaneal bursitis, this would be the area where you'd see fluid accumulation if there was a tear. And this is a nice, healthy tendon. This picture here would be what a full rupture would look like of the Achilles tendon. This isn't my patient, by the way. Just want to let you know that. I just want to give you a picture of what a full rupture would look like. So this would be the short axis view. You can see there's absence of the fibers of the muscle of the tendon there. And along, this is in the long axis view, you can see there's retraction of the tendon here. This is all the area where the tendon should be. This is all the retraction of the tendon in long axis view. So obviously you can see there's no fibular pattern, there's no tendon. And basically this is my patient. So this is the day of her evaluation. So you can see here in this section here that there's a significant loss of that fibular pattern of the tendon. You could start to see a little bit of swelling accumulation, a fluid accumulation right over here in that retrocalcaneal bursa. And in short axis view, you can see the absence of the fibers over here and over here. So my impression, I'm sorry, this is the peroneal tendon region I scanned as well. You could see her lateral ankle, you could see the fluid accumulation around the peroneal tendons. And in long view, you can even see the thickening, like the thickening of the tendon here, a little bit of tendinosis and swelling within that tendon as well. So my impression was that there was localized hypoechoic signal in the anterior portion of the distal Achilles tendon of the left ankle with loss of normal fibular pattern, suggesting a partial tear and localized effusion. And there is diffuse hypoechoic signal around the peroneus longus and brevis tendon, suggesting of effusion. So we did some PT intervention. She received physical therapy for about 2 months. We did modalities for pain and swelling. We did some phonophoresis, IFC, some cryotherapy. We did therapeutic exercise for strengthening, stabilization of her ankle. We did some range of motion, joint mobilization to left ankle to maintain mobility, some proprioceptive and balance exercises. We did some taping techniques to provide some support to her foot and ankle because she's a yoga instructor and she was barefoot a lot. So she needed to have some sort of support on her foot and ankle. So we did some McConnell taping to accommodate her arch and give her a little bit of a lift so she had some support. I give her a lot of education on modification and avoidance of activities that put stress on her Achilles tendon area. So at the end of 8 weeks, she was reporting decreased pain. She was demonstrating decreased swelling of her Achilles and her lateral ankle. However, she continued to report some tenderness in her Achilles. So what happened, because she was feeling so good, she decided to play tennis. So she came to me saying about, just about 3 months in, that she had re-injured her Achilles after attempting to play tennis. She reported she stopped short, she felt a sharp pain, and felt a snapping sensation in her Achilles region. So when I looked at it, there appeared to be more swelling in the region of her Achilles tendon, and there was a lot more tenderness to palpation. So I decided to do another MSKUS of her ankle at the time of the visit to assess these new symptoms. And this is what I found. So when I looked at her, I noticed, comparing to the first image, that there was definitely more fibular, loss of, the tendon fibrillation there. There was, a lot more, looked like there was more tear. She definitely had a lot more swelling and, fluid accumulation into that retrocalcaneal bursa. And on short axis view, you can see there was a lot more loss of the tendon fibers. And her peroneal tendon actually looked better. So you could see there was a lot less swelling around the tendon. The tendon looked very smooth and normal. So my impression this time around was these findings are a comparison of the study completed on May 11th. There was localized hypoechoic area in the anterior portion of the distal Achilles tendon of the left ankle with loss of normal fibular pattern, suggesting a partial tear and a fusion of the retrocalcaneal bursa. These findings are suggestive of worsening of the partial tear and localized effusion located in the retrocalcaneal bursa compared to the previous study in May 2018. There is no evidence of effusion around the peroneus longus and brevis tendon with normal appearance of the tendons compared to previous study in May 2018. So the follow-up after that visit was I recommended that she follow up with her doctor to possibly be immobilized in a cam walker to prevent worsening of her injury. I made a phone call to the doctor to discuss her MSKUS findings and the worsening of her condition. I sent those findings to the doctor. The doctor suggested to do a follow-up MRI just to confirm the MSKUS. The MRI findings came back with insertional Achilles tendinopathy with chronic low-grade 10 millimeter anterior fiber tear centered at the superior calcaneal process and a low position soleus with peritendinitis and significant bursitis. So the doctor decided to place the patient in a cam walker for about 4 weeks and discontinue all activity until follow-up with the doctor. So I saw her about 3 weeks later. She came into the clinic. She was anxious. She wanted to know if anything got any better. So she said, "Can you scan my ankle again? I want to see if it's healing at all." So I said, "Okay, let's do it." So I brought her to my office and I did another follow-up scan, and you can see the healing of the tear right over here. You can see it's a lot less. The other tear actually extended all the way to here. So there was definitely more healing, a lot less fluid accumulation. I mean, there still is some fluid accumulation, but a lot less. This is just another view of that long axis view. And then on short axis, you could see that things are starting to come together there. The tear is a lot smaller. Still some fluid accumulation, but definitely a lot less than that scan that I did, 3 weeks prior. So my impression this time around is that this is a comparison study from August 10th, and there is localized hypoechoic signal in the substance of the distal Achilles tendon insertion of the left ankle, which is consistent with the previous finding of the focal partial tear of the distal anterior fibers. However, the retrocalcaneal bursal effusion appears to be improved than last study. There is improvement noted in the fibular pattern of the Achilles tendon, suggesting healing of the tendon. So the rest helped. So on conclusion, basically in summary, she had her initial injury in May. I did the MSKOS showing a partial tear of her Achilles tendon and peroneal tendinosis. She received physical therapy intervention for about 2 months. She re-injured in July. And then I did an MSKOS follow-up showing worsening of that tear. She then had an MRI concurring the MSKOS findings, and then she was immobilized in a cam walker for 3 weeks. MSKOS at that time showed healing of the Achilles tendon and no change in her peroneal tendons. So I just wanted to share you guys, how we can use MSKOS to show, ongoing injury and progression of injury and, progression of healing, rather than just, upon the initial evaluation and that's it. It'd be, it's a good way to keep the patients motivated, showing that, especially with this patient, because she was so active and, she just didn't understand that she needed to slow down and stop doing everything. So I really just needed to show her, listen, this is what happened. You did too much. Now you made it worse. And also to show her that by immobilizing and resting and doing the right thing, it actually can heal. Any questions?
That was really good.
Thank you.
Laura, my question would be only because of my presentation. Do you feel that doing a dynamic scan with a contraction would have helped you in any way with figuring out the severity?
Probably, yeah. I mean, I didn't do that with her. I just did a still picture. But, I'm assuming, if I did like a dynamic scan, on that first study. I actually didn't see your presentation. I missed it. Is that with you? You did Achilles?
Yeah, Vicky had a great case on Achilles too.
Okay.
Yeah.
So if I had done a dynamic scan, it would have been interesting to see if those fibers separated a little bit more.
Mohini, what is the biggest benefit in your opinion of scanning dynamically?
So there are a lot of benefits. Now let me tell you in terms of like partial and full thickness. I think there is more benefit in full versus partial. Although in partial you can exaggerate that defect or maybe make it look more obvious, so you can see clearly the fibers splitting or separating and the fluid going into that space. It does help in visualizing, understanding the three-dimensional nature of that focal defect. But in complete tear, like the case that you presented, dynamic exam helped us understand that this is a complete tear. It can be confusing because you have tendon tear and there's bleeding there, hematoma and fibrosis, and sometimes you think that there are still some fibers intact while there aren't any. And when you do dynamic exam, you see there is no translation of that movement, so it's not moving, and the calcaneal movement is not translating to the tendon, attached tendon, which you believe to be attached tendon attached there. Or sometimes you see paradoxical movement, which we see in shoulder abduction test, where when you do test for impingement and you ask the patient to abduct, if there is no supraspinatus, the movement is reversed. So when muscle is contracting, so the bone movement and the muscle movement is in opposite direction because we are looking at deltoid. There is no supraspinatus. So dynamic exam always helps. But whichever special test you do, if you add ultrasound to that, you understand the problem much better. And the fact that there is so much swelling around that area and there are other synergistic muscles around that area, you can still tease out the specific structure which is injured or is abnormal.
Thank you. It just helps me to think with it because I know that I need to do more dynamic scanning.
Yeah, I agree.
That was really good. You did a great job on that. That's really awesome that you were able to see the before and after aspect of that.
She was a good case study to work with. She was very excited to help me out.
Hey, good presentation, Laura. That's great. And that concludes all the presentation before the symposium. And we hope to see everyone next week, next weekend. Any other questions